Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Andrew Moshfeghi of the USC Roski Eye Institute. Andrew, welcome back to Retina Synthesis.
Thank you very much.
There's been a tremendous amount of interest in high-dose Aflibercept as the next step in the commercial development of Eylea. And today we'd like to talk about the Pulsar study, which was a study of 8 milligram Aflibercept for the treatment of neovascular AMD. You were involved with that study and recently talked about it at the Clinical Trial Summit. Tell us about Aflibercept 8 milligrams.
Sure. Well, we are all accustomed to regular dose Aflibercept, 2 milligrams, which is used for all of the classic indications for retinal vascular disease like neovascular AMD, retinal vein occlusion, diabetic retinopathy, diabetic macular edema. But one way to try to get not only increased potency, but duration of action would be to increase the dose of the drug. But we are somewhat limited by the amount of volume that can be injected into any given eye, especially on a repeated basis. And so what the company did was to develop a higher molar dose of the drug, 4 times the dose, 8 milligrams instead of 2 milligrams. But the 2 milligrams is normally delivered in 50 microliters. And this 8 milligram dose is delivered in a slightly higher dose, 70 microliters. So it's not like 0.1 cc's, but 70% of that. And so high dose with the hope of getting a longer duration of action and more potency. And this study was looking at neovascular AMD.
So what was the study design?
So they took on-label regular dose, 2 milligrams of Eylea, and one of the labeled indications regimens for neovascular AMD is to do 2 milligrams every 8 weeks following 3 initial monthly loading doses. So that was the control arm in 336 patients. And that was compared to 2 other arms, 8 milligrams every 12 weeks after 3 initial monthly loading doses, or the third arm, 8 milligrams every 16 weeks after 3 initial monthly loading injections, the similar number of patients as the control arm. Primary endpoint was mean change in best corrected visual acuity in a non-inferiority statistical analysis at basically 1 year, week 48. And then patients were followed for roughly 2 years. Now that's the overarching 30,000-foot view of the study design. There's a lot of little nuances in terms of what constitutes the Q12 week 8 milligram arm and what constitutes the Q16 week, since we know that perhaps not everyone in those arms might be able to go to those long durations in between injections. And so what they did is they came up with these sort of dose regimen modification visits starting at week 16 in the experimental arms. And then those visits, based upon whether there was a 5-letter loss in visual acuity or more, or a 25 micron increase in central retinal thickness, intervals could be shortened. So if you were on the Q12, you could be shortened to the Q8. If you were on the Q16, you could also be shortened to Q12 or Q8 subsequently. So they had several of these DRM visits sort of interspersed between weeks 16 and week 44. It wasn't every visit, but it was at precise visits throughout, such that no patient would ever go less than every 8 weeks, including those in the experimental arm, which weren't subject to these DRM visits. But in experimental arms, no patient could go less than every 8 weeks.
So what were the results?
Well, so for one thing, patients were nicely balanced at baseline with respect to demographic characteristics, visual acuity, and OCT metrics. With respect to the primary outcome measure of non-inferiority, with respect to best corrected change in visual acuity, the lines were nicely overlapping such that there was statistical non-inferiority. There was not inferiority. So they met their primary endpoint with respect to visual acuity. And that was great, such that when you look at what about all those DRM visits where they could have been pushed down to a more frequent dosing interval, didn't that just drive these Q12 and Q16 week best corrected visual acuity numbers? Not really, because when you look at those arms, 80% of patients in both arms approximately were able to maintain their initial regimen assignment of either Q12 or Q16. And over 83% when you pull that data, were able to stay Q12. And so despite having these opportunities to get to a changed regimen, only about 1 in 5 patients needed to change the regimen. And with that approach, they were able to get very similar data that we've become accustomed to with Eylea Q8 weeks. And this results in, fewer number of injections on an annual basis, as well as, perhaps greater patient acceptance of this long-term regimen. One metric that I found particularly compelling was that, I told you those dose regimen modification DRM visits didn't start until week 16. And remember, all 3 arms had loading doses at 0, 4, and 8 weeks. But we had a Kaplan-Meier survival curve analysis looking at time to a fluid-free central subfield on OCT. And really the median time to a fluid-free center for both the Q12 week arms was only 4 weeks. So really after the first injection at their first follow-up visit, the median number of patients had achieved a fluid-free center in the 8 milligram arms, both of them, compared with 8 weeks, so 1 more visit for the standard dose 2 milligram arms. So for those that thought, well, maybe this whole messing around with the regimens things is kind of making everything murky, I can't really interpret the data. Well, you can if you look at it before those dose regimen modification visits occur, because they don't occur until week 16. So during those first, 12 weeks, it really is more of a head-to-head analysis. And, most people make treatment modification decisions on the basis of the appearance of the OCT. So the fact that this high dose of Aflibercept was able to, get over 50% of the patients dry in the central subfield by week 4 compared to week 8 for the 2 milligram arm is particularly compelling in my opinion, especially when the Harbor study looking at ranibizumab, we didn't see a positive outcome in that study. So I think this is a particularly compelling data.
So what was the 16-week data like again?
In terms of visual acuity?
Visual acuity, my question is this: what's the expectation what percentage of Aflibercept patients can be treated at 16-week intervals?
Yeah, so roughly 80%. It's really 77% were on the Q16 week interval. And when you look at those visual acuity curves, it's very good. It's slightly below the 2Q8, and of that Q16 week initial patient assignment to that regimen, 13% of them were bumped down to Q8 weeks, and 11% of them were bumped down to Q12 weeks, but 77% of them stayed at Q16 weeks. And with respect to, visual acuity outcomes, there was 6.2 letters gained for the 8 milligram every 16 weeks, 6.7 letters gained for 8 milligrams Q12 weeks. And that's compared with the control arm, 7.6 letters for 2 milligrams low dose, Q8 weeks. If that answers your question.
Yeah, it does. This was a phase 3 trial?
Yep, pivotal study. And, the visual acuity data also nicely gel with, the OCT data nicely gel with the visual acuity data. It's not like we see one of these two important metrics meeting our expectations, but then the other one kind of being a little bit disappointing. No, really both of them are nicely overlapping lines for each of the cohorts when you look at visual acuity over time and when you look at central retinal thickness over time. So I think it is fairly compelling. In my opinion, the only drawback really is, the newness perhaps of this high concentration of the drug, as well as the fact that, it's not 8 milligrams and 50 microliters. It is a slightly higher dose, slightly higher volume of 70 microliters. And, I've had patients where I've injected regular dose Aflibercept, and I accidentally gave a little bit too much, and, the patient comes out NLP for a few seconds or a minute or so. And so this is, like every patient could have that opportunity with 70 microliters because it's more than what we're used to. Now, do I expect every patient to end up NLP? No. Did that happen in this study? No. So, there are mitigation strategies that people can employ when doing the injections to help soften the eye, such as applying tamponade to the sclera, all for like maybe 15 to 30 seconds with a cotton swab ×3 prior to doing your injection. That sort of helps the eye pre-auto-regulate before administration of a large volume of drug. I've already been doing that for patients receiving pegcetacoplan for complement inhibition with geographic atrophy for dry AMD, because that's 100 microliters. That's even a higher volume. And I haven't run into any patients yet having me needing to do a anterior chamber paracentesis with that approach. So that it does take a little bit longer. And that's one drawback, but if you're only doing the injections every 12 or 16 weeks, a little bit longer injection prep may not be that unreasonable.
So is there any estimate of when this will be FDA approved and available?
Yeah, the PDUFA date is like in 10 days. So once FDA makes their decision, I'm sure Regeneron is poised to commercialize it and distribute it pretty quickly thereafter. It won't have the same billing code as regular dose Aflibercept. So I don't know if they're coming out with a temporary J code during that period of time. They probably will, is my guess. And so that might be something that would slow uptake in the first few months.
And there was a parallel photon trial in diabetic macular edema. What did that show?
Very similar outcomes with photon study for DME. Can't quote you all the numbers off the top of my head, but very impressive outcomes overall.
So the future of Aflibercept is at the 8 milligram dose, it would appear.
Yeah, I mean, I think that that metric I talked about, time to a fluid-free central subfield, I think tells you, this isn't just for the long run that you might switch a patient who is requiring frequent injections to this regimen. You know, if you want to get patients dry quickly, this might be the way to do it instead of being more conservative and starting with 2 milligrams. That being said, my understanding is it's not that 2 milligrams will be going away. It will not. Since that's the dose that's used for some of the other indications like retinal vein occlusion and the like. So at least for a while, I think we'll have both doses available.
Well, Andrew, thank you for your time and thank you for this very promising news about Aflibercept 8 milligrams.
My
Thank
pleasure.
you.